We'd now like our panelists and speakers to join us at the podium, and we'd like to use this time to take questions from the audience. So if you could use the microphones and identify yourself, that would be terrific. Yes, please.
Julie Mundy, cardiothoracic surgeon from Brisbane. I just wanted to ask a little bit about the practice reviews that the orthopaedic surgeons are doing in New Zealand. Are all surgeons potentially practice reviewers? Who chooses who will review which surgeon? Does the reviewer have a choice? Does the reviewee have a choice? And is it feasible that you could have someone who's had their fellowship for 1 year reviewing the senior 60-year-old head of department, grey-haired person that might have examined them a year previously and given them or not given them their fellowship on the first attempt?
I'm afraid I'm going to have to plead a lot of ignorance. I don't know if Alan Panting is able to comment. Alan's a senior orthopaedic surgeon and also Director of Surgical Affairs for our branch of the college.
Oh, thanks, Andrew. In answer to that question, there is careful matching of the reviewers with reviewees, and there is two reviewers, one of whom will be in a subspecialty allied to the person being reviewed, one who may be in a different subspecialty, and their seniority is balanced. So you'll have a junior and a senior, so that there is a mix. And the aim is that this will spread across the whole of the association. Everybody is involved as reviewers before they're reviewed.
Thank you.
College of Radiation Oncology. For people who are reviewed who are not happy with the outcome, is there a
well, it's again not a punitive process. It's a learning opportunity between the reviewer and the reviewee. If an issue was escalated toward the council, and to challenge any aspect, and council would not make a itself. So we only have the 3 instances where the medical officers have been phoned. Whether the reviewer and the reviewee want to have a bit of an argy-bargy about it, I guess, is outcome of it if it's unless there are serious concerns raised. Well, no, I don't necessarily think so, because we see this being run by the colleges as until they become perhaps an issue for public health and safety, which is sort of the colleges to sort out, plus minus employers, etc. So even if it became mandatory, there would be a major problem created simply by it being mandatory.
Could I ask Dr. Lockyer about English language proficiency amongst .40 commonly used languages for which interpreter services are provided, and clearly the views of those patients are dealt with that in the patient questionnaires that you're using in Alberta.
So on the development end of the instruments. We have tried to get the language level down early. I know of instances where physicians serving special populations when they were, as they call it, when we were parred. So I expect that many people aren't given the opportunity to be one of the 25 respondents. Systematic, every 5th patient or every some routine patient, but I expect their office staff
urban academic health centers are pretty multicultural, and I think they even have interpreters for Stryan.
BJ Roach, I'm with the College of Obstetrics and Gynecology, and I think that you've addressed that's from the part of the participants or the reviewers or the profession as a whole. Within our groups starting to dominate their areas and their potential impact on the generalist. And who will review us? Because if someone reviews me in an area that they, not necessarily subspecialise, and to push their own agenda. And the other two parts that go with that is that there is self-interest. There's self in Australia with huge numbers where people will be competing with one another, and so therefore it will be in their interest themselves because it will promote their own agenda.
Yes, in New Zealand, you know, our data is early, it's small numbers, and it may well have started association have you know, some pretty broad way of opinions in that group, I would suggest, have understanding what the process is about. It's not about saying you're better than Jim next door and Sue down the lead to some pretty hefty sanctions if advertisements, for instance, were to come out in the local 8.5 and he got a 6.9 on communication. So I think it's part of a way of reassuring ourselves that we are actually up to speed. I do go back to the fact that the public want to know that doctors are buying into this, and I think we're in what it means and missing what it does actually mean, which is it is designed between the two parties, or the three if there's a couple of reviewers, whatever, and it needs to be orthopaedic surgeons, you know, they have, if there's a subspecialist being reviewed, I think an opportunity also to highlight the importance of generalism and through, etc., and we'll learn from other jurisdictions.
Thank you.
hearing from New Zealand, and sorry I came late, is what is the preferred view of each of the regulator, if you like, in inverted commas, an independent body or somebody else? Of how you see things running.
Andrew, I think you've already started.
It's a contract between the fellow and the college for the vocationally registered, so we believe the ever believe that where there's non-compliance that there should be, I'd go so far as to say mandatory reporting to council. But we would see it as run by the colleges for their fellows, obviously in conjunction with the
Of patients' views taken into account?
Well, patients' views with multi-source feedback practice, there might be a lot of patient interaction with that the reviewer involves the outcomes for patients, but the tool or the approach has to be flexible enough for pathologists. However, if you're a histopathologist who's, say, doing FNAs in breast clinic, it would be quite appropriate. With those patients would be a very important component.
Okay, we've got a couple other people waiting, so we might move to the other side of the room.
One of the big issues in pathology practice is individual workload and how you deal with base. But I was surprised that this didn't seem to be a big issue in any of the presentations that occurred. And what decisions were made in the assessments, whether that was appropriate or inappropriate, and what remedies were put in place. Assessments.
I think, by workload, do you mean workload of the review or workload?
Workload of the individual. How many procedures they do in a working day, and whether that's appropriate or inappropriate for safe practice.
In the sense that there is a specific section that looks at job size, if you like, which includes those aspects in terms of whether it's excessive or appropriate, but also how that fits into the service in terms of what the service's obligation, if you like, or what the service wants them to be doing in terms of service provision. So I think it is key. Practice clinical review that just purely looks at performance and clinical knowledge, etc.
Okay, next question at this microphone.
Stephen Dean, Surgery, Newcastle, Australia. I'd be interested to know related tools require inputs, and particularly collegial and co-worker inputs. What are we, and there's a multiplier. What are we learning about the maintaining the rigour and integrity of those inputs? Compliance tool from the point of view of the people giving.
I don't, yeah, I'll answer, I'll just take a stab at that. I don't think don't think they're overburdened. I think the overburdening is more likely among a group of physicians.
Anyone else on the panel want to tackle that, David?
Trying to encourage people to use these tools, and we haven't got to any state of to encourage people to get confident that multi-source feedback isn't going to bite them, it's actually going to help them improve. That individual's practice actually belongs to them and is actually not going to be released to other people, and is actually there for if there was a problem of underperformance, that will be dealt with by other methods other than, in fact, the performance assessment.
I think this is part of the culture change and part of the mainstreaming, if you like, of some of these tools that are used, that though they may and box ticking, etc., that they need to be incorporated into practice so that they actually do result in practice improvement. They're actually useful tools that we use.
I wonder if I can make a brief comment on that as well. We require multi-source point that you were making, that we didn't want to get sort of burnout, or we didn't want it to feel as a what you were making earlier. MSF strongly indicated that it's the first 360-degree feedback that has the most impact. That's when you have the happens.
Thank you. We'll take this question and return here for the last question.
With Andrew and your comments about the presentation here last year, in view of his book called What Patients Want, I took it patient advocacy group in Australia, and on it, going back several years, I cost and access to pharmaceuticals, health insurance premiums, obesity, diabetes, smoking, pain, but there were no postings concerning doctors' competence or wanting revalidation or suggesting examined by their peers. As far as asking surveys about patients about these sorts of course they are, but what I would suggest is that patients already know that into medicine, that we have exhaustive exit exams. I think if we tell them that reporting of poor performance, unprofessional behaviour, dishonesty, drug, alcohol abuse and so on and so forth, I think
we is doubling every 75 days. Yeah. I think, in a lot of the graduate programs. What we know about at the moment is that the public review Australia. I think what this is about is anticipating the changing nature of medicine, the changing views of citizens in various countries, and as you well a decent rugby team. But look, I don't think shift from what you're already doing and what the public are already happy with. It's, I suppose, regulation and evidence-based competency programs, and
about now is really more of a public relations exercise.
No, not at all.
Than actually what we need.
No. Look,
necessary.
well, I'll give you an example from dermatology. In New Zealand, we have a group of dermatologists surgery, and they're doing that not actually with the training they've received through the RACP, probably extremely valuable and extremely competent, and we don't have a competency concern about those dermatologists. Later, we are confident that those skills are indeed being maintained. We don't go in and supervise. It's often done in the rooms, but having a colleague come in maybe once every 5 years to see that your steriliser wasn't purchased deserve. So that's my counter-argument.
Yeah, as far as the surgical thing is concerned, I understand what you're MO surgeons and so on, and they do that as conscientiously as I'm sure your college
I'm sure
does.
They do, yeah.
Michael Greco, I'm Chief Executive of CFEP Surveys Australia. We've been doing multi-source feedback for some time now. Their MSF tool, and to run it across a sample of about 1,500 doctors to get it some of the issues around are burdensome and workload, and some of these things are already for example, in general practice land, every GP practice has to be accredited, and within that is a 4,000 GP surveys over the 3-year period, is the tool around interpersonal competence. So the GPs, as part which is the patient feedback bit of the multi-source feedback. So I think, you know, Joanna's point earlier was really valid, that there happening. What I've heard this morning around CPD programs, there's already things happening in that space. So it was more of a comment. So, thank you.
In this country, and I'm sure in many other countries, there is progressive income. So task substitution, new medical professions. What do the regular for quality of care, and how can these sorts of programs be moved out into those new?
Shall I have a bash at that? And then I think we in the medical profession we all work in teams, and teams are really important, and every member of the healthcare team is really important. To make a diagnosis, we deal with uncertainty, we manage risk, and we accept ultimate responsibility. That we need always to be clear about what a doctor is, not what a cardiologist is or an orthopaedic surgeon. that we're involved in. If we do that, then I think that we will be more comfortable with identifying what do better than we do. But as a colleague of mine in the UK said, when somebody said, well, 80% of what you do could be done clear about what is special about what doctors do. Don't be conservative and reactionary about keeping stuff.
Right. Well, thank you very much, Peter, for those last comments. Could